Welcome to The Explainer. Today we're going to explore one of the most incredible high-stakes medical tightrope walks in modern medicine, the treatment of severe burns. When we think about burn injuries, we naturally tend to focus on the visible damage, right? But behind the scenes, deep inside the patient's body, there is a massive invisible crisis unfolding. We're going to break down exactly how critical care teams use precise mathematics, relentless vigilance, and dynamic on-the-fly adjustments to pull patients right back from the brink. So let's kick things off with a pretty crucial question. When someone suffers a massive burn, what do you think is the greatest immediate threat to their life? It's actually incredibly common to assume that the fire itself, the tissue damage, or maybe a massive infection is the immediate killer. But in those crucial first 24 hours, the true threat isn't what you see on the surface at all. It's something entirely different, and it is far more systemic. The real hidden killer is burn shock and massive fluid loss. To really wrap our heads around this, we need to think of the human cardiovascular system as a closed plumbing system. Normally, your blood vessels do a fantastic job of keeping fluid perfectly contained, just pumping it round and round to deliver oxygen to your organs. But when a massive burn occurs, the body's profound host response kicks into high gear. Suddenly, that closed plumbing system springs thousands of microscopic leaks simultaneously, all over the body. You are losing massive amounts of fluid. But here's the crazy part. You're not losing it onto the floor. You're losing it from the inside of your blood vessels straight into your surrounding tissue. All right, let's break down exactly what this phenomenon is. Medical professionals call it burn shock. The textbook definition describes it as intravascular hypovolemia, which basically just means dangerously low fluid volume inside your blood vessels, caused by massive fluid shifts from increased capillary permeability. Because the blood vessels become so leaky, the fluid just escapes, leading to severe tissue swelling or edema. And because there's suddenly way less fluid in the pipes, cardiac output dramatically drops. The heart literally has less blood to pump, meaning vital organs stop getting the oxygen they desperately need to survive. And this severe fluid shift, it hits its absolute peak in those first 24 hours. Now this brings us to a very critical threshold, 20% total body surface area, or TBSA. To put that into perspective, 20% is roughly the surface area of your entire back plus one arm. At this specific threshold, a localized injury transforms into a massive systemic crisis. If a burn is relatively small, the human body can generally compensate. But once a patient suffers second and third degree burns covering 20% or more of their body, that localized inflammatory response spirals into a massive systemic event. This is the exact point where formal, mathematically calculated intravenous fluid resuscitation becomes absolutely necessary for survival. Without immediate intervention right at this threshold, cardiovascular collapse is a certainty. Okay, let's dive into this because treating burn shock is what critical care doctors refer to as a Goldilocks goal. You are threading an incredibly fine needle here. On one hand, you have under-resuscitation. If you don't give enough fluid, the patient remains in shock, their blood volume continues to drop, and they suffer acute kidney injury or total organ failure. But on the flip side, we have over-resuscitation. If you give too much fluid, you exaggerate that tissue swelling. The tissue swells so intensely that it can physically crush blood vessels and nerves, a terrifying condition known as compartment syndrome. Or it can cause fluid to back up directly into the lungs and brain. You have to find that exact, perfect middle ground. To achieve this perfect balance, doctors rely on a very specific tool. The absolute blueprint fluid used for burn resuscitation is a crystalloid solution called lactated ringers, or LR for short. Now, you might be wondering, why not just use normal saline or pure water? Well, because lactated ringers is carefully formulated to closely mimic the actual intravascular solute content of human blood. It basically acts like a substitute for what's already inside our vessels, making it the absolute best choice to replace exactly what is rapidly leaking out. So how do they figure out exactly how much to give? They use a specific math formula to find their starting line. For adults, it's a straightforward three-step process. Step 1, take 2 milliliters of lactated ringers. Step 2, multiply that by the patient's body weight in kilograms. Step 3, multiply that result by the percentage of their body surface area that has second and third degree burns. This gives the care team the total volume of fluid the patient needs for the first 24 hours. Depending on the patient's weight and the burn size, this formula can mean pumping in 10, 15, or even 20 liters of fluid in a single day. And get this, exactly half of that massive volume must be given in just the first 8 hours to combat those severe capillary leaks. And this brilliantly illustrates how that formula is quite literally just a starting line. If we look at the actual fluid volumes required over the first 40 hours, they arc sharply upwards in the first 8 to 10 hours.
Fluids often have to be actively dialed way up to meet those intense early fluid shifts. Then, as the blood vessels finally start to heal and seal back up, the care team slowly and safely tapers the fluids back down. The true life-saving doesn't happen on a calculator. It happens right here, through these dynamic hour-by-hour adjustments. This level of dynamic adjustment relies on some incredibly strict, relentless rules. Doctors absolutely must reevaluate the patient every single hour. And how do they know if the internal organs are getting enough blood? They use target urine output as their primary physiological feedback. It's brilliant in its simplicity. For adults, if the kidneys are producing 30 to 50 milliliters of urine an hour, the fluid rate is perfect. If the output drops, they adjust the IV rate up by a maximum of 1/3. If it's too high, they dial it down by 1/3. And crucially, they never just dump in rapid fluid boluses unless the patient's blood pressure is totally crashing, because sudden spikes in fluid will just immediately worsen that tissue swelling we talked about. Let's move to and see how this builds, because this mathematical balancing act becomes even more complex when we're dealing with special populations. The roles drastically shift depending on exactly who the patient is. Children under 14, for instance, have a much greater surface area relative to their body mass compared to adults. This makes them highly susceptible to fluid shifts, so their formula starts at 3 milliliters, not 2, and their target output is weight-based. Then you have high-voltage electrical burns. For these cases, the starting volume jumps all the way to 4 milliliters, and the target urine output shoots up to a massive 75 to 100 milliliters an hour. Now, why such a massive jump for electrical burns? Well, it's because of a terrifying red flag: dark, red-tinged urine. When high-voltage electricity surges through the human body, it causes severe, deep muscle breakdown. This breakdown releases a protein called myoglobin straight into the bloodstream, a condition known as myoglobinuria. And myoglobin is highly toxic to the kidneys. If it just sits there, it will physically clog the kidneys and completely destroy them. That is exactly why the fluid volume and the target urine output have to be so incredibly high. The care team has to aggressively flush the kidneys to clear that pigment out and save the patient's renal function. So, what happens if an hour goes by, you're monitoring a patient, and their urine output suddenly drops? The absolute first thing the medical team must do is check for a simple mechanical obstruction. Is the catheter just kinked or dislodged? You always check the plumbing first. But if the catheter is perfectly clear, the problem is hypoperfusion, meaning the kidneys simply aren't getting enough fluid. The solution then is to incrementally increase the IV fluid rate. Under no circumstances should doctors give diuretics, drugs that force urination, because doing that artificially destroys the very metric they're relying on to monitor the patient's true blood volume. As if this high-stakes balancing act wasn't tough enough already, there are certain scenarios that make it exceptionally difficult. Patients dealing with associated mechanical trauma from a car crash or maybe severe lung damage from inhaling smoke require incredibly nuanced fluid management. If a patient's treatment was delayed by several hours, or if they were injured in a highly toxic environment like a methamphetamine lab explosion, their physiological responses become wildly unpredictable. And patients who already have prior heart or kidney failure, they are at an extreme risk for fluid overload. In all of these scenarios, picking up the phone for an immediate consultation with a specialized regional burn center isn't just a recommendation, it is absolutely vital. If there is one core thesis to take away from this entire explainer, it's this: math provides the starting line, but relentless human vigilance is what actually saves the life. Those formulas, the 2 milliliters or the 4 milliliters, they are incredible medical advancements that give doctors a solid place to begin. But a patient doesn't survive a massive burn just because of a calculation on a clipboard. They survive because nurses and doctors stand right by their bedside hour after grueling hour, checking precise physiological feedback and carefully titrating fluids up and down to match the dynamic chaos happening inside the body. Which leaves us with a pretty fascinating thought to conclude on today. We've seen just how dynamic this process is, reacting hour by hour to the kidney's output. But if the human body's response to severe trauma is ultimately this mathematically driven, how might future technology, perhaps continuous intravascular sensors or AI-driven monitors, predict our exact fluid needs before the kidneys even have time to react? As medical science continues to evolve, this high-stakes balancing act of burn resuscitation may one day become faster and more precise than we ever thought possible. Thanks for joining us for this explainer. Keep learning and stay curious.